Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
With type 2 diabetes, the brain ages faster in them than other people. So that's a new finding that hasn't been addressed in terms of looking at people with type 2 diabetes who are controlled or uncontrolled and see what's happening to their brains as they age. And they found that in type 2 diabetes that they age fast, the brains age faster than normal. And they also had a study that showed that the liver stays young. We know that the liver can regenerate, but there's evidence that while the rest of the body is aging, the liver cells stay young. Anyway, just thought I'd share that with you because those are interesting new findings that you might be interested in learning about. Any comment about those things?
Yeah, Dr. Callender. These are two types of diabetes.
Yes.
I've forgotten which one is which now. Diabetes mellitus and diabetes.
Type 1 is diabetes that most younger people are born with type 1 because the beta cells of the pancreas don't work at all. So that's type 1 diabetes. And it's usually found in people who are born with it and some adults. Not too many, but some adults have type 1 diabetes. More commonly, type 1 is found in white people. Type 2 is more common in blacks and is associated with insulin resistance rather than the absence of the insulin cells. It's the fact that the body develops antibodies to the insulin, and so the insulin is not effective. So those are the two types of diabetes. Type 2 is usually associated with older people. Type 1 is usually associated with children, infants.
Okay. These two names given to them now, these insipidus and mellitus, which one, how?
This is mellitus what we're talking about. Diabetes insipidus is really a condition of the brain. Which affects the ability of the kidney to excrete things. But we're talking about diabetes mellitus, type 1 and type 2.
All right. Thank you.
Cheryl Tatum.
Okay, John, you can start the show going.
Okay.
You know, as we talk about treatment for cancer, you have more individualized cancer treatments that will become common in the future. So you'll take out your own cancer cells, treat them, and your own T cells, treat them, and then after they've been treated, give them back to you to see if their T cells will now kill the cancer cells. Anyway, that's the future. This is an interesting article that talks about the best time of day to exercise. And I think in our group, members of our group exercise probably differently. For example, I exercise in the morning. Some people exercise during the day and some exercise during the evening. So, the question is what works best for you in terms of your schedule. Most people do it based upon the time that's easiest for them to exercise and not interfere with the rest of their daily activities. It does appear that there is a difference between men and women in terms of which works best. For example, they say that in the evening, it's better for men and for women, it's better in the morning. I think that it's interesting to see that, but that it's an individual thing where you have to work out when it's best for you to exercise and do it uh, willingly and positively. Of course, in terms of belly fat, I don't think men or women are particularly fond of belly fat, but it does say that one exercise with women helps them with belly fat. It's interesting that we talked about this before, but belly fat is not good for you, whereas butt fat does not interfere with your health, whereas belly fat does. So if you have women who have big butts, they may still be healthy, whereas the belly fat people have more kidney disease and other such problems. Now, the only problem with this study is they didn't have a large number of participants, as you can see.
Dr. Callender, I have a question. As far as exercise is concerned, if you exercise before you go to bed, you don't. I don't think you get the muscles a chance to diminish naturally. Whereas if you exercise in the morning, early in the morning, and your muscles can be still stimulated.
Well, I don't know that. I'm sorry, you weren't finished. I thought.
Yeah, as you go throughout the day, your muscles kind of relax a little bit, but there's still some benefit.
Well, I think there's benefit, but I don't think anybody's suggesting that you wait to do it before you go to bed. I think they're talking about doing it in the evening, maybe 4, 5, 6 o'clock after you've come back from work. Because for some people, it's a matter of convenience. After a day of work, they don't want to do it. They want to do it early in the morning. Or some people feel they have more time, so they can do it at 5 o'clock, 6 o'clock. I don't think anybody is suggesting that you do it before you go to sleep.
Yeah,
Yes,
it
it's not a good idea.
depends on how vigorous the exercise is, because you want muscle recovery, and with vigorous exercise, you need a cool down period, and you also need to eat within 90 minutes of doing vigorous exercise. And so it's kind of problematic if you wait until the evening hours before you go to bed, because you don't give a adequate chance for cool down or for refueling by eating within 90 minutes.
Good points. Okay, but there's little question that exercise is important. And so women and men need to do it. What time they do it depends upon you and your particular schedule. But the points that Darryl made are good ones.
As far as men goes, for people that are into vigorous exercise routines, it's kind of long established fact that the risk of heart attack is greatest in the morning for vigorous exercise.
Yeah, the association of heart attacks in the morning is an interesting one. Okay, next one, John. Now, this is an article that talks about things that we discuss all the time: longevity and health. And it's no surprise that all of the things they've mentioned we've talked about before, but they talk about it, the role they play in maintaining health. It is not apparent to me why anybody who's over 40 does not exercise, because I think that's the key to one of the keys to longevity. But there are I think close to 30 to 40% of the American population does not exercise, at least does not exercise 150 minutes a week. So, and we saw the article about the 10,000 steps and how they said that 7,000 may be adequate. In terms of nutrition, there's little question, as Darryl has pointed out, and others have many pointed out, that a well-balanced diet, particularly plant-based, is ideal, but a well-balanced diet is emphasizing fruits and vegetables is important. And they mentioned, of course, the salt and sugar and trans fats that take you to an early grave, they say. And then, of course, the next thing is the your basal metabolism rate. It's nice if you've got a rapid BMR, because then your basal metabolism rate is BMR, because then your food, your diet is done away with quickly, and so you don't gain so much weight. Because slow BMR is not good for you. Yes.
Dr. Callender,
Darryl Tatum.
the paragraph before that talks about older adults and protein
Yes.
that we,
Yes.
okay, we use more protein.
Well, we also break up protein and muscle more as you age, and that's why exercise also is important, because having the protein helps you restore the muscle that you lose,
Right.
because as you age, you break down the muscles more rapidly.
Right.
Most people think their protein source is meat, but there's plenty of protein in plants, particularly dark green leafy vegetables have more robust protein than red or white meat.
Dr. Callender, I have a question about metabolism. How do you measure that?
That's it's different. It's interesting because there isn't a way to measure that I know of. We do BMRs rarely in terms of diagnosing people whether their metabolism rate is slow or not. So practically, I think you'd have to go to a metabolism specialist to get your BMR tested. But it's clear that when you look at people, there are people who are the thinnest, people who generally have the fastest
No, that was on metabolism.
metabolism rates.
Dr. Callender, is it likely that somebody that has their body mass index within a normal range is going to have a high BMR?
Yes, it's likely, very likely. And as Darryl has mentioned many times, the ideal is between 20 and 25. And those persons who fit in that category usually are have a rapid BMI, basal metabolism rate. Yeah.
Dr.
Chronic
Callender,
diseases. Yes, go ahead.
I'm sorry. What about this big push about protein powder? You hear everybody taking protein powder, protein pancakes. And so any insight on that regarding the amount of protein?
No, I just think that protein is important. How you take it, whether you take it in vegetables or other sources, I'm not big on it. Darryl, you got any thoughts about it?
Yeah. The protein kick started in like 60s or 70s once scientists discovered that you could get bigger muscles by eating a lot of red meat. But you know, actually, he has bigger muscles because it's striated with fat. It's not necessarily stronger muscles. It's just bigger and you weigh more. So we got this fascination with protein in America, where you know, let's say use a protein powder, get as much protein as you can, but we get way more protein than we actually need. You know, we have so many other problems in our diet, uh,
Yeah,
but we have overabundance of protein, in my opinion.
Oh, okay.
yeah, I think it's exaggerated as well.
My
Uh,
question, Dr. Callender,
yes,
your BMR, is it better for it to be slow or medium or fast?
it's probably good to be medium, but uh, it's clear that the leaner you are, the healthier you are. So if you're going to have, if you're going to have something other than a medium, it would be a rapid one. Yeah, that would keep you lean.
Thank you for that.
It's interesting that chronic disease is so common among those of us who age that it then becomes even more important to take care of yourself. And of course, one of the things that kills more people as they age than anything else is falls. And so exercising and keeping your muscles appropriate minimizes the falls. And that's why I think there was a discussion about protein, because you need to have enough protein to build your muscles, and your muscles need to be strong in order for you to keep yourself from falling. Mental health, of course, is something that we treasure, but we don't really seem to know how to. Well, we know how to, but we tend not to maximize those processes that maintain your mental health. We talked earlier about the ways of keeping your brain active and how important that is, because without stimulation, the brain atrophies more, and tends to be associated with dementias of one kind or another. Yeah. So your mental health, it becomes important. The power of positive thinking is not just a good statement. It's a finding that's associated with longevity. Then emotional health, of course, interacting with others becomes an important part of your emotional health. And groups like this and other such kind of social interactions, like going to church and other things, are good for you and keep you alive. Any thoughts? Any other thoughts on tips on longevity and good health that we didn't discuss?
Dr. Callender, the people whose jobs are associated with constant movement, either walking or using their hands, do they need as much, or do they need extra time for exercise?
Well, everybody needs time for exercise. So I'm not sure I understand your question. I mean, we know that 150 minutes a week is a minimum, but that doesn't mean that you can't spend many more minutes in exercise. And the more that you exercise, the better, up to a point. So, but that may not be answering your question. So, did you have something else in mind?
No. I see people who move about all the time with their legs, in
Yes.
their job. And then when they get home, they're exhausted, they're tired. Do they have to go and do some extra exercise?
No. I think the movement is wonderful because it keeps the circulation going.
Yes.
And so it's desirable. And then when you're tired, you just you recover.
Yeah.
Darryl has talked about his marathons and the rate in which he recovers from them. And so the exercise that we're talking about is minor compared to that kind of exercise. But recovery is important from whatever exercise you do, so that after you finish exercising, you do have to have a period to recover.
Right.
We just
Dr.
have a
Callender, another way that to look at this is my father, who almost lived to be 102. His secret was that he remained active. I mean, he's like Dr. Atto was saying, that one of these people that's always walking, always doing something, hammering a nail, this, that, the other, just busy all day long, active all day long. And that was the key to his longevity. But another doctor told me that when you're doing just your daily activities, that doesn't count as exercise.
Well, that's true. I don't think anybody would argue that. The difference is that it's often that people who do gardening or that in many ways is exercise. So that's not part of your daily living. That's extra. That's gardening. I think what they mean is if you're just doing what you normally do, that is not considered exercise.
Yeah, we just live in a sedentary society over here, and a result of that, most Americans, you can tell Americans anywhere in the world because we're fat. Most of the people in the world are not. You go to Europe, and the normal routine for a European is that they go to the grocery 2 to 3 times a day. They walk to their jobs instead of going by car. Most of the time in Europe, you walk rather than drive. You're going to carry your groceries. You're going to do vigorous chores. Most Europeans have the body weight in the normal range. And for a lot of them in their society, they're getting an adequate amount of exercise through daily activity. But it's hard to do with daily activity in America to get enough exercise because we drive everywhere. We're
Yes, it
lazy.
is.
Spend a lot of time looking at the TV. So for us, we got to make a special concentration to get exercise because our lifestyle has given us no exercise.
Well stated.
Well,
Well, one thing that is suggested that you move every 30 minutes. And that keeps you moving. And I think about teachers that did walk, talk, and chalk. We never sat down. We were always constantly moving. And so that's one thing that is suggested that, if you're not a person on the move, try and move every 30 minutes.
Good advice. Okay. This is an interesting study because there's many who believe the opposite of this, that sugar shortens your lifestyle. But most Americans are sugar addicts and wouldn't think of having coffee without sugar. And this study that they did in UK demonstrated that those who had sugar lived a little longer. I'm not sure what that means, but anyway, that's what they found. So it's amazing. You have studies that study almost anything. Who would have thought they'd study whether or not you have sugar in your coffee? But anyway, it's one of the few studies that are going to show that sugar is good for you. You know, many other studies down that show that sugar is good for you.
No, if I read them, they don't stick with me. I just take them with a grain of salt and move on.
Yeah, okay. But there's a preponderance of studies that show that sugar and salt are are not healthy.
Mm.
Now, this is an article I wanted to include because I want to remind us about the fact that cancer is still highest among our ethnic group. And we're not really sure why. There's many studies. As a matter of fact, Harold Freeman won the Alaska Prize in 2000 for indicating that one of the reasons that Blacks have more cancer and die from cancer is because they get diagnosed late. And when they get diagnosed, they do not get the treatment that is appropriate for them. And this then has been a reason to say that it's not associated with your ethnicity, but every time we do studies, it turns out the same way, that being Black is associated with a higher incidence of death from so many different causes. Cancer is one of them, but there are as well.
Dr. Keller, do they say that it's higher in Black men versus Black women, or just Blacks in general?
Black men and women. Men and women. If you look at, compare Black men to white men and compare Black women to white women, it's still higher mortality rate.
Is it all types of cancers, or some cancer in particular?
It seems that it's most, because there's so many different types of cancers. But
Yes.
most cancers that we know of, it's associated with it.
Dr. Callender, I noticed, go ahead.
No, go ahead.
I noticed that the paragraph 4 talked about the death certificate. Now, I watched this show about this mortician and how she classified the death. And so they get the information from the death certificate, look like.
Right. And it's clear that the death certificate is not without fault, because doctors put down whatever they decide to put down as the cause of death. And sometimes they put down the wrong things. So when it's related to, if your only connection is the death certificate, it's not 100% accurate, but it's one way of following things. And just about every study that I've seen shows the same thing, though, that Blacks have a higher cancer rate for just about, and you're right, there's special cancers. For example, prostate in men, it's well known. Breast cancer in females is well known. And some uterine cancers as well. So it's a general statement, and there may be exceptions to the rule, but in general, Blacks have higher cancer mortality rates.
Okay.
So
I think I can find my articles that say that these high cancer rates are for African Americans rather than just all Blacks. Because if you look at sub-Saharan Africans, which are Black, prostate and breast cancer rates are much lower, even though their health care is probably worse than ours. You know, we don't get the best health care in America, but there's less health care opportunity in sub-Saharan Africa. So, you know, if we're Black over there and Black over here, but do worse with cancer with Black over here, then it's probably diet rather than access to health care.
Well, that's a presumption, but it has not been proven. And for the most part, when they talk about Black patients, they are talking about African Americans, and so that's true. But I don't know that there have been studies that have been conducted that are able to differentiate the good point that you're making, that when you use the term blacks, what do you mean? And so that is not identified in this particular study. But when we're talking about United States, they tend to lump Africans with African Americans, and that's one of the problems with having blanket statements, because ethnicity is different, and that's why, to me, the issue of race becomes an important issue, because if you talk about Asians, I mean, the ethnicity becomes important. What part of Asia are you from? What part of Africa are you from? As you pointed out, are you an African? Are you an African American? Or are you? And the other thing that people would want to talk about is, if you're an African, how long have you been in away from Africa? Or are you somebody who just came over from Africa, or you somebody who's been here for a while? And so there have been studies that have demonstrated that there's a
Dr. Callender,
significant
I've
difference.
been,
Let me
I
finish.
participate.
Let me finish, please.
Okay, I'm sorry, doctor.
There's a lot of studies that have demonstrated for kidney disease and other diseases that they differ based upon whether you are an African American, an African who's been in America for some time, and you're somebody who's just recently come over from Africa, which goes back to what the point Darryl was making. And so therefore it requires that we do more when we label people, so that you're able to really make definitive statements about what is the cause of death. But in general, when they talk about it in the United States, they generally lump African Americans and Africans and Caribbeans as well all together. Okay, so I'm finished. You can make your comment.
Elizabeth,
No, that was Marlene.
oh, Marlene, go right ahead.
That was Mary Ellen.
Mary Ellen, go right ahead.
I was, okay. I was just saying that I have been participating for the last 5 years in a study at Howard University, where we were studying the effects of exercise and diet in Black people. And I specifically sought out Howard University for my Medicare, because I felt that as a Black person, I would get better treatment with Black doctors. And that's another thing that they were trying to find, if that had a correlation. Plus, we don't get in studies. Most of the time, these studies that they do not have minorities. And we need more studies with Black people, because a lot of times we're not even an afterthought.
Very good point. That's been one of the criticisms of most of the studies, is that they don't have a significant enough of Africans who are involved in the study, and nor do they have enough clinicians who are of color either.
Dr. Callender, is
Yes.
there any part of the body that cancer does not really affect and hit? I know we get a lot of information about, prostate cancer, breast cancer. Is there any part of the body cancer doesn't touch?
No part that I know.
Oh, wow.
Dr. Callender, the other question is, if Blacks have more cancer, is it true that, a lot of the Black people who have cancer are the vital organs that are so commonly cancerous, stomach, esophagus, kidney, all the internal organs.
I don't understand your point. What is your?
My question is just, is it true that the internal organs are hit the most?
Not really, because you have a lot of skin cancer. You have a lot of skin cancer, just that we as blacks don't have as much skin cancer as whites. We do have malignant melanoma, but as far as the other skin cancers, we don't have as much skin cancer as white people.
Another difference genetically is that black people, 75% of us tend to be lactase non-persisters, whereas only 25% of white people are lactase non-persisters. And that has to do with lactose intolerance if you can't digest dairy. So we're, and if you're in America, chances are you're eating the standard American diet, which is very high in dairy products. And if you can't properly digest it, you may be setting yourself up for cancers.
Correct. This next article talks about having drugs that could help more people if people were more aware of the availability of the treatments. And this is a medication that blocks HER2 protein on cancer cells. And they're suggesting that if this were used more often, it would be effective, which is an indictment of the physicians as well as more an indictment of the physicians than the patients, because the doctors gives you the option of treatment, but also tells you about which treatment may be effective. And when they make the diagnosis of cancer, they identify whether you have these receptors or not. And there's certain chemotherapy drugs that are good for those who have receptor and those who are without the receptor. And so this article is indicating that some people who actually should be getting the drug are not getting the drug. So this is really an indictment of the cancer doctors and making available some of the treatments. And of course, one of the things relating to availability is the price, right? And so when the drug costs $14,000, it's kind of tough to do. Just like I recently saw an article on a lady whose medication cost $1 million, and she had to go do a fundraising event to pay for her medication. And so not all medications are equally funded. So making sure your doctor's up to date, knows what is the best treatment for each type of cancer, especially breast cancer, is important. And that's one thing that you would think that your doctor who's a doctor of color would be more sensitive to. The monkeypox issue, we talked about it the last time, and it's still with us, and there seems to be an increasing number of patients who have the virus, and it's occurring in countries outside of Africa. It really began in the Congo and other places in Africa where it's endemic, but now it's spread to numerous European countries and the United States. As we talked about the last time, it is unlikely that it will become pandemic, but it is endemic in some locations. And we're finding more and more cases of it in Europe.
I see it's in the same family as the smallpox, huh?
Right, yeah, it is, yeah. Same family. It's not nearly as lethal, but it's the same family. And the vaccine for smallpox is effective against it. Okay, let's go to the next one. It's, as time goes, we will probably see more of that. This is another article on monkeypox, which is still very uncommon, but becoming more common, but not common. And I think the fact that it is appearing in Europe outside of Africa indicates that it is still around.
Dr.
Fortunately,
Callender, I'm sorry. I saw a headline. I didn't get a chance to read it, that there was a case in DC of monkeypox.
yeah, okay, yeah,
Yeah, Dr. Callender.
yes.
Yeah, and they have banned the sale or marketing and consumption of monkey meat in Nigeria now. But
Oh,
to ask you is, do you happen to know the primary mode of infection? Is it ingestion or otherwise?
the primary mode of infection is the lesions, contact with the lesions where the virus is. You have ulceration and you have virus in there. And if you have contact, it's not transmitted like COVID. It's committed by contact. So
And talking about this cancer in general.
are you talking about cancer?
Yeah, this cancer in general. Do you happen to know what is the state of gene therapy, the research on gene therapy on cancers?
Yeah, I remember we started the
Huh?
discussion of the case I talked about with the treatment of cancer by taking the person's cells out of the body and putting them into taking the T cells and putting them in an environment and then giving them back. And so this is a type of gene therapy as well. So the gene therapy is part of some parts of cancer treatment. And then I think the more effective treatments are the ones that are immunological. For example, taking the cells out of the body. And then there are other immunotherapies in which they use antibodies that knock out the protein that prevent your cells from killing cancer. So right now, those are the most common cancer treatments. Immunotherapy along with chemotherapy are medications that are toxic to the cells. Gene therapy is used, but not as common as the immunotherapy and chemotherapy.
So they have not been able to successfully isolate the gene and manipulate the gene, introduce the gene into the host as a method of treatment.
So far, I'm not familiar with any therapy in which the cancer is caused by a gene, and in which the eradication of that cancer is treated by deleting that gene. So to answer your question is, I don't know of any instances in which cancer is caused by a gene and that gene has been removed in order to treat the cancer. Because now we're talking about using deleting genes and in order to eliminate a lot of diseases, but I'm not familiar with gene therapy that is effective at treating a cancer that is caused by the gene itself. And that's the question you're asking, right?
Yes.
Yeah, I'm not familiar with a cancer that is caused by a gene that has been cured by deleting that gene. As we know with the new gene deleting treatments, and we are now treating genes that cause disease by eliminating that gene, but we're not identifying cancers that have been treated in that fashion yet. I'm sure that'll come, but we haven't been doing that yet. But we're doing that for many other things, especially in transplantation. The recent xenotransplants have been associated with gene deletions, and there's evidence that there are genes that are associated with causation of kidney diseases. But I'm not familiar with that being the situation with cancers and the gene therapy being used to treat that cancer yet. Now, this is a kind of inflammatory article that there's been a lot of concern about what goes on in China. For a long time, they have taken patients from death row and use them as transplant candidates. I'm sorry, as donors. As
Wow.
donors. Right. And so they stopped that practice theoretically in 2015. But so up until that point, they were using criminals as donors. And now there's evidence that they are still using donors who are not yet brain dead. Because if the patients are breathing, then the brain is functioning. So this article is identifying more instances in which this violation is still occurring. And there's a lot of animosity between the European countries and China because of the fact that this is thought of as illegal. And there have been a number of groups that have protested against China because of these so-called violations. Because it's inhumane and it violates the medical rules, so to speak.
Dr. Callender, this act probably is one that maybe some Americans may fear. You know, when you say I'm going to be a an organ donor, and they think, well, they're going to take my organs whether they should be taking them or not.
Well, we have rules that indicate that you can't do that unless the patient is already dead. So we have a dead donor rule here in the United States, but they have it in most of Europe, but in China they were violating that rule. However, that was one of the common reasons why African Americans were reluctant to become donors early on. That is not as common anymore, but it is still one of the reasons that some people give for not wanting to donate. Now, this is an interesting study because what this proposes is that they have found a treatment that prevents COVID from affecting the cell. And this interaction between the different sialic acids, when administered prevents the virus from infecting the cell, and it's hoped that eventually, it's not available now, it's hope eventually they'll become an aerosol treatment that can be used to prevent, even if there's somebody who has COVID, prevent that person from infecting another person. So but this may take another 5 to 10 years, but the fact that this has been discovered means it's something that people will be working on in the future.
Finally, we got an article where sugar is good.
Well, this is not sugar, actually. This is not sugar. This is, I thought of one of the people in our group who talked about somebody who had COVID reinfection again and again.
Yeah.
And
Yeah, my new one.
and I think one of the consequences of having a vaccine is that you can get an infection and not be severely ill or die. And therefore that means you can be infected again. But fortunately, it is not likely to result in severe symptoms and death. But reinfection does occur. And that's the benefit of the vaccination. And sometimes people forget that having a breakthrough infection without hospitalization and death is a direct consequence of having an effective vaccine.
So Dr. Callender, is this, so then, since they say COVID is not going away, is this where we will be getting maybe a COVID shot once a year like the flu shots? And will it be just one, or will we have to get
Makes it likely.
boosters and?
Yeah, makes it likely.
Mhm.
Time will tell, but it does make it likely. Yeah. Now, during this period now, you see fewer and fewer people wearing masks and fewer and fewer people social distancing. And it gets getting so that if you wear a mask, you're an exception to the rule. Although it's encouraged, it's not required. So it's interesting to see how this is going to play out in the long run. And I think that's why Tony Fauci was suggesting that in the fall we may have a situation in which maybe 100 million Americans become infected again with COVID. One of the things that you have to keep in mind, though, is that some of these people who get the Omicron infections will not be protected from future COVID infections. And that's something that the vaccine will give you that the infection may not. So there are many reasons why it's important to have been vaccinated.
Right.
Dr. Callender, do Black people get COVID more than white people?
That's an interesting question, and it's hard to answer because it's we know that in the United States, Black people have died more, but I don't know the answer to the question as to whether Black people get more COVID. We know that we die more, but I don't know that we get it more than white people. And that study has not yet been revealed.
I noticed that they were giving out a lot of COVID tests. at one point, and I noticed that when my husband went to the wellness center, they were just giving out in abundance. But then when he got home, I looked at them, it was going to expire in 2 months.
Yeah.
So it's the expiration date. Is there any life after the expiration date, a month or something?
Not that I know of. No.
Okay.
Dr. Callender, we have annual shots, the flu shot, the pneumonia shot, the shingle shot, the COVID shot. Do you perceive monkeypox to become widespread like COVID?
No. The World Health Organization said it's extremely unlikely because it's not transmitted like COVID.
Mm-hmm.
It's transmitted by direct contact and not by transmission through the air for the most part. So no, monkeypox is not expected to be a pandemic.
Okay.
There's still a significant population. I think it's something like 20 to 25% of the population still is not vaccinated.
Mm.
And this will be the group that is likely to be infected and resulting in hospitalizations and deaths. And the point you're making about the testing is a good one, because in the fall, when we're going to have that rebound thing, those tests would not be effective. And so who's going to fund the tests? Because now they're free. But Congress did not approve the funding for that. So what's going to happen? That's why that there's a lot of concern, because Congress did not authorize funding for that. Even for the vaccine that you will want to be taken in the fall, that is not included in the funding. Now, this is an interesting article because at one point was felt that Paxlovid, which is the new treatment for COVID, would be given to those patients who are high risk or symptomatic and needed hospitalization. So, but now it is now authorized to treat people who are not severely ill. This is what this article is all about. Before it was for high risk patients and patients who became very symptomatic. Now it's suggesting that it could be used to, even in those patients who are low risk. So, and the criticism is that it may not be necessary if all you have is one symptom or very few symptoms. Do you need Paxlovid? And what they're suggesting is that it can be given even if you're not high risk. So if you turn positive and you had no symptoms at all, or if you had one symptom, you could take Paxlovid if you wanted to. Whereas before, you had to have high risk.
What do they mean by low risk? What does that mean?
That means that you don't have comorbid infections like diabetes or hypertension, or you don't have chronic disease, cancer, or immunosuppressed. That's what low risk means. If you have a chronic disease, then that makes you high risk.
Dr. Callender, is it possible that some people may have natural immunity for this COVID and its variants? And if
Yes.
so, if there is any mechanism to identify such people and then study them and maybe enhance our knowledge of this virus?
Yeah, it is. Yeah, because you can do the antibody tests and find out. Yeah, they can do that. It'll take a while, but it hasn't been done yet, but it can be done. Yes. Now, this is a study that has been done, and it takes a while to do because remember, the vaccines are a little more than a year old now. And so there's an interest in seeing which is best, although as far as I'm concerned, when you have success rates of above 70%, that's pretty effective. So, and far more effective than the flu vaccine. But anyway, it was thought that be appropriate just to look at the 4 vaccines that were administered and see how they fared at preventing the COVID. And so you could see that Moderna had the highest levels of neutralizing antibodies, although Pfizer and Novavax had lower. Still, we're still talking about very effective therapies, which talking about 60 to 70% effective. So all of them, any of the 4 are better than the flu vaccine's results. So that any of the 4 vaccines that were administered are better than the flu, although it looks like Moderna was the top, but Novavax might have been the lowest. J vaccine had high percentage of memory cells, which means that you'll be able to fight off. Yeah. And these all are the T and B cells, are the cells that the antibody and the cells that fight off infection. So I guess the bottom line is that all of the vaccines are effective. And although Pfizer was the top, even the lowest ones are better than 70%. So that's pretty good. So we have to give kudos to the vaccine makers because they, in a very short period of time, came up with very effective vaccines. And this time they had people who were tested from virtually all ethnic groups. In the past, they've had predominantly white people, but they had good sampling of people of color as well as white people, which is a first. And so we are making progress. We're not where we want to be, but we are making progress.
Yeah, I got a question about the cost of drugs, particularly with the COVID vaccines, because you'd think that, well, COVID vaccine is it's a drug, but it's cheap enough, everybody's getting it for free. But then again, you've got, like we talked about earlier, the $14,000 drugs, cancer drugs, and there's $1 million drugs out there. Are drug prices, are they really related to the cost of research and manufacture, or is it just whatever the market will bear?
No, it's related to the cost of developing the drug. And even the vaccines that are no longer in the covered by Congress. So in the fall, when there is a COVID vaccine that's developed, it's going to cost us, because unless Congress decides to put it in the budget, which it hasn't. But I answer your question, it's the cost of research and development.
Yes, because you have, if it's federal, if there's any funding involved in the drug production, it lower the cost.
Right. Right. But,
So-
and what made this vaccine free was that the government paid the price. It's not that it was really free, it's just that the government paid for it.
But you know something, when I was a comptroller and I had to select insurance for my corporation each year, the representative will always encourage me to have the young and the childbearing employees, and try and have no employee over 60 on my payroll. And but my thing is, look like the insurance should be considering possibly funding the vaccine, because of the fact that you won't have as many people getting sick using the insurance and running up the cost of the insurance. But then what they do is drive up the premium. Okay, I forgot about that part.
Yeah, because that's why it was hoped that Congress would include it in the budget. So, but they haven't as of yet. So we may have a problem come fall, unless we can convince the Congress to do that. Now, melatonin is a drug that some would say is useful, some say is useless. But it's for the most part used for people who have insomnia. And it was originally thought as being harmless, over-the-counter drug. But some people with insomnia take so much of it that they get poisoned by it. And especially in the younger people. And so this has now become a concern. I don't know if any of you have used it, because it's over the counter. And if you go to Australia or places where the time zone changes, and you come back for a week or two, you may have trouble sleeping. And this is medication that is used by very many to overcome that zone insomnia. And as a consequence, they're finding that some of the teenagers are abusing it and getting sick. And they talk about the fact that it affects breathing, and which was apparently the commonest problem. It says over 10 years, more than 4,000 kids were hospitalized in order to help them breathe. And both younger than 2 died. Why would you give somebody younger than 2 melatonin? I mean, that doesn't make too much sense, does it?
No.
But anything that you can imagine is done, I guess. Yeah. And then you can imagine during the pandemic, when everything's isolated, that people would be taking melatonin so they can go to sleep. But and taking more and more, and therefore the toxic effects happen. Any of you take melatonin?
I've taken it before.
Did it help?
When I go, yes, it does. It doesn't put you to sleep. It makes you well, it aids in falling asleep. I know sometimes when I go out of town, I'm excited and happy to be somewhere else, and I don't fall asleep when it's time to go to sleep. And that's what I take it for, so that I'll go to sleep.
It works
And
for
the
you.
one that I use is by the people that make it's called ZQuil, and it's by the people that make NyQuil. Because one of the side effects of NyQuil was that it makes you sleepy. And I know people that used to take NyQuil not when they were asleep, but when they needed to go to sleep.
Uh-huh.
So this is who it's made by, and it's called ZQuil.
Any other comments about melatonin and insomnia? Well, people who travel, you're right, it's very common among them. People who travel, especially if you go to places like Australia and other places.
Yeah, for people that have melanin in their skin, the more time you spend outdoors in sunlight, the more melatonin you naturally produce. So, they recommend that everybody spend at least 20 minutes a day in sunlight. But if you're having sleep problems, get outside more.
That's safer.
Sleep outside.
Yeah, well,
Just sunlight and everything.
yeah, a lot of other things too. Now, this is an article I put in there because we all know that the healthcare provider for whom patients have the most confidence in is nurses. And doctors are behind, but nurses are at the top. And this article talks about the 4 things doctors can learn from nurses about patient care. Sometimes one of the problems is that the doctor thinks that he knows more than everybody else. He can't learn from the nurses, which of course is a big mistake. There's some areas where the nurse and OB and in surgery may know more about the instruments than the surgeon. So it's important to recognize that it's a team effort, and the nurses are the part of the team that is with the patient longer than anybody else. As a consequence, it's important for all of the healthcare team members to work together. So the number 1 item is collaboration. And nurses tend to be more collaborative than doctors, and doctors need to learn more about effective communication, because that's what prevents mistakes, collaboration and effective communication. And then there's a little question that, well, for the most part, nurses are in nursing because they care. Doctors are in healthcare because they care too, but the attitude of nurses may be more positive and more associated with caring than doctors. So caring is another aspect of it. And then patient safety is critical. And effective communication is what keeps things safe. And communication between doctors and nurses becomes absolutely essential. And if you find something wrong, collaboration becomes even more important, because the sooner you detect something that is a problem like that, the more likely you are to be able to solve it before harm is done to a patient. And the emphasis is on what is best for the patient rather than on anything else. And then spending more time with patients. You know, when I first started doing transplants, I used to sleep in the bed next to the patient. So for that was, of course, I started in a time before they had intensive care units. So I was the intensive care. And so, and because when I started transplants at Howard, and nobody else knew much about transplants, so I slept in the bed next to the patient, close by. And so then this was a situation in which I spent as much time with the patient as the nurses did. So, and this is something that, and now is associated with the intensive care unit, where doctors spend more time with the patient. But anyway, these are four critical elements that we as team members, nurses and physicians, need to optimize. Yes, nurses can learn from physicians and physicians can learn from nurses. And the closer we are together as a team, the better off things are for the patient, who, after all, is the focal point and the center of all of our efforts.
Dr.
Any
Callender,
comments?
yes. Is there any real difference between a nurse practitioner and then a doctor? Because some of my friends, they don't have any personal doctor or personal physician. They have nurse practitioners, and then they were told that what the general practitioner can do, a nurse practitioner can equally do. Is that statement correct?
Well, it depends on your perspective. In other words, a nurse practitioner is allowed to do many of the things that the physician traditionally does. The difference is that they're perhaps not as expensive, but they have a nurse practitioner degree. They don't have a medical degree. So yes, they can do many of the things that physicians do, and they are trained to do many of the things that physicians do, but they do not have the same degree. But yes, they can diagnose and treat patients and order medication.
Okay.
And the reason nurse practitioners are there are because we don't have enough physicians.
Okay.
And so as a consequence, because of the shortage of physicians, we have nurse practitioners.
All right.
One question about the nurse practitioners. Are they, what percentage of them are waiting to get their medical degree, or they're just going to stay there as a nurse practitioner?
They stay there as a nurse practitioner because if you want to be a doctor, you have to go to medical school. So
Okay.
there's a different school for nurse practitioners.
Right. So
The nurse
none of
practitioner
them,
school is about 2 years, I think.
yeah, so none of them are interested in, maybe some of them are interested in getting a medical degree in further school.
I'm not aware. I don't know, because most of the nurse practitioners I know are nurses who decided to become nurse practitioners because it was a step up, and a step up in salary as well, and other things. And none of them seem to be interested in getting the MD. PhD, yes, but not MD.
Okay, thank you for that. That answers that question.
They are
Doc-
they're master degree people that get certified to be nurse practitioners.
Right, and there are a lot of the nurses who get that degree may go on to get a PhD, but But you're right, it's 4 years for medical school.
Yeah, I noticed that they used to send them in rural healthcare centers.
Absolutely, that's where it started off. Because they
I
had no
have a
doctors at all.
I have a nurse practitioner.
He's cheaper.
I'm sorry?
If you have, like you said, if Mary Ellen has a nurse practitioner, then she's paying less money.
Probably. I'm not aware of what the prices are. I know that the degrees are different. Now, I put this in there because I wanted to get some comments relative to the fact that student loan forgiveness plan exclude physicians. What are your thoughts about that? Of all the groups that have loans, the MD is probably spends about $200,000 for his education in medical school, and as a consequence, the student loans for other professions is going to be forgiven, but not the huge loans of the doctors. What do you think about that? What are your thoughts about that?
My first thought was ability to pay back. They probably think that in the profession of doctors, they make so much money, they're not going to have a problem as other fields to pay the money back.
Yes, and then my second thought is job acquisition, and after the training, other degrees you got, you're not sure of securing a job, whereas as a physician, you have guaranteed to get a job, and then of course, as Mr. Tatum said, the salary.
I was
Well,
thinking, doctor, that a lot of time physicians can get help with their tuition if they go into healthcare I don't know what it's called, but
public health service.
I knew some doctors that got their medical paid when they went to Mississippi to work.
Right.
And
Right.
I
Yeah.
also knew some that if they went into the Army, they paid their medical tuition.
Right. In other words, they do have forgiveness plans if you go to places that are in need. And so you can wipe out your loan by just going, as you mentioned, to places like Mississippi or places where there are doctor shortages. And you can wipe out your loan. But you're talking about loans that are upwards of $200,000.
Dr. Callender, to me, those are two different things. If you go to medical school and you get a loan, that you got to pay that back. But these other people who go to the Army or go to Haiti or wherever they go, their money comes first, and then they go. They don't have to get a loan.
No, that's not true. That's not true. In other words, NIH has specific programs. When you finish medical school, if you go to these specific locations, your loan is forgiven. And if you
And there are people that go in the Army and there are people that get their medical degree and then go into the Army to get
right,
and they don't join the ROTC before or any of that. They do that after they've graduated.
right,
I've
right.
known.
Yeah, and the other source is what we're talking about is the public health service.
Right. That's another source. So there are ways of doing it, but if you choose not to do that, then you're going to have to pay that money back.
Yeah, well, I think it's unfair not to give anybody, any profession, student loan forgiveness. We need more doctors, and things like student loans, at $200,000 or more, that's a deterrent to being a doctor, plus paying your malpractice insurance. And not all doctors are rich, so you can't make that assumption. My next door neighbor is a pediatrician, and she's my next door neighbor. That proves she's not rich because she's in my
Yeah,
neighborhood.
well, wait a minute, wait a minute. Now hold on. That presumes that you're not rich.
No, she's not rich. I've seen her house.
But I mean, maybe both of you are rich.
I tend to agree with what Darryl is saying about the need for physicians, and I want to even pump it up to maybe even the possibility of national health care, because we're one of the few countries that the government doesn't provide health care for everybody. And
Actually, we're the only developed country.
I really think that is a need that has not been addressed, that should be addressed. And in order to get that, you're going to have more doctors. So yeah, loan forgiveness for doctors would help that to happen, I believe.
Well, I can show you who's at fault for this situation because we have the best politicians money can buy, and so our doctors did not buy our politicians.
Absolutely. Absolutely.
Any other thoughts? Well, it's an interesting. I was surprised that they did that, but oh well. I guess that's the way it goes. Now it's interesting that Mexican bans the sale of e-cigarettes. I'm not sure why it got to that point where that they had to do that. It always we already know that there are health concerns, questions, but to me, I don't know that there's any greater health concern than smoking per se, which is already a problem. And the reason they haven't banned nicotine is because of the people who have made billions off of cigarettes. But it's interesting that they would keep cigarettes but ban e-cigarettes. That's interesting. Because they ought to ban the sale of cigarettes, not e-cigarettes, cigarettes.
Yeah, Dr. Collins, it's the difference between whether you're banning stuff for health reasons or you're banning something for financial reasons.
Well, for health reasons, there's every reason to eliminate tobacco.
Right. But for mafia reasons,
But what?
Is the mafia.
Oh.
In Mexico, you got the mafia, and they want to control the e-cigarettes. So.
Oh, I see. So, well, it's interesting to see that dichotomy. Because if you look at which kills more, it's probably likely that the nicotine kills more than the vaping cigarettes. Okay, any comments you want to make before we leave today?
Yeah, I got something really quick. This is kind of a victory for old folks. I've got moderate hearing loss. I got 49% in the left ear, 51% in the right ear. And I've been checking out the cost of hearing aids. You go to an audiologist, they recommend hearing aids for 5,000 or more. Online hearing aids, they range from as low as $600, but the cheaper stuff is more visible. It looks like you're wearing a hearing aid. It's not color match. If you're dark skinned, it's a hot mess. And Costco, $1,700 to $3,000 at Costco. None of these options were very attractive. And just because I did the searches in YouTube, I got a YouTube clip about using AirPods Pros as hearing aids. And I already had a pair of AirPod Pros. And so I downloaded a hearing test app, created an audiogram. I customized my AirPod Pros with my audiogram, and I can hear. Now I can hear normal conversations. I didn't like the TV because I thought it was a bunch of noise. I couldn't understand the dialogue. Now with TV at low volume, I can hear it. I can actually hear what my girlfriend has to say. For Okay, the downside is the iPod Pros, AirPod Pros cost $200. And the charge lasts for 4 hours. They say most people with hearing aids need them on for 12 hours a day. Well, I can get by with 8 hours, which just means I need another pair for $200 instead of a $5,000 hearing aid, and I'm good to go. And I'm glad about it. I'm rejoicing. I'm shouting hallelujah. I'm the happiest man in Chicago today.
I think
Wow.
that's wonderful. Chris lost his hearing,
That
but thank
is
God for PA.
wonderful,
He got his.
especially in the light of the fact that Medicare does.
Congrats,
Right.
congratulations.
That
So,
is wonderful. That's excellent.
hello.
Because I noticed
That
that Medicare does not cover hearing aids.
That's
Right.
true.
Yeah.
And so when I'm wearing my AirPods Pro, just like I'm a cool kid, listening to music or waiting for a phone call, I'm looking like I'm wearing a hearing aid.
Are you a veteran?
No, I'm not. I'm a draft dodger.
Okay. All right.
Darryl, can you get arrested by the police for distracted driving when you have those pods on?
In Illinois, I have to be holding a cell phone to my ear to get arrested for distracted driving. With the AirPod, no, I don't get arrested. I know my law, I know my rights. I can only get arrested for driving while black.
Okay.
Which is the unwritten law.
Dr. Callender. Yeah,
Yes.
please. Yes, going back to this gene therapy. I remember in the 1980s or prior, there was some research going on on the insulin gene for diabetes, how to use the gene as a therapy for diabetes. But the mode of transporting the gene into the host was a very tough one. What is the status quo now about research in that area?
Well, I think pancreas transplant is now a treatment. Islet cell transplant and whole pancreas transplant has replaced that, so that gene therapy is not part of the treatment for diabetes. So, for example, with type 1 diabetes, the treatment of choice is probably pancreas transplant, islet or whole pancreas. And so gene therapy is not part of the treatment therapeutics anymore.
Yet they're still doing gene editing for diseases.
But not for diabetes yet,
Yeah.
because we haven't found the gene that causes diabetes.
What do you know what diseases now they're trying to cure by editing the genes?
Yes, they have. For example, there's been a gene editing for cardiac hypertrophy, which is a fatal disease. And so those diseases that we know that the genes produce the disease and it's fatal, gene editing can be used for those.
Mhm. Thank you.
Dr. Callender, I sent you an email about one of my friends who just had a liver transplant the other day, and he's at Georgetown ICU, and he's doing very well. I had invited him to the group, and he's on the email list, so he's been getting our articles. But prior to getting this transplant, he was so overwhelmed with all the tests and everything that he had to do. But I just wanted to report that he's doing well and he's recovering. He's breathing on his own now. And I did have a question about him. He had put out a GoFundMe on Facebook about a donor, a partial donor. What can you tell about people who received partial livers instead of a whole liver?
Well, living donor living transplantation is a therapy of choice now, because they can take out part of the liver. Remember, we had a liver transplant surgeon present to us, and we had Lynn Johnson talk to us about the fact that the liver can regenerate itself. So now living donor liver transplantation is an accepted treatment of choice so that if you have a child, and you can take part of your liver and give it to your child, and that liver will grow and heal the child, and your liver that they took out will regrow. So that living donor liver transplantation is similar to the success with living donor kidney transplantation.
Going forward with the donor, has there been any research or data collected about the success of the donor?
Yes, there's been much research on all aspects of living liver donor transplantation. And as a matter of fact, one of the people who made the presentation actually did their first liver transplant, I think 2 weeks ago, 3 weeks ago. And we might invite him back again to talk to us about, but they're not doing living donor liver transplantation at Georgetown or George Washington. They're doing the deceased donor transplant that you spoke of with your friend, Chris.
One last question. When you slept next to your transplant recipient that night, how old were you?
Oh, I was 30, about 30, between 30 and 35. That's 50 years ago.
Wow.
Yeah, I think I was among the first to do that, because they didn't have ICUs in those days. And so I would sleep in the bed next to them or in the room next to them. And eventually, of course, we got an ICU, so I'd sleep in another room. But yeah, that was a long time ago.
I thought a half a century.
Yeah, it was interesting. But I knew that I didn't want to be far away from my patient. So for 6 weeks, actually, after my first kidney transplants, I stayed in the hospital. That didn't do well for my role as a husband and a father, but it did well as a transplant surgeon.
So you were the ICU.
Yeah, right.
I
You had to
do
monitor
see
all. Yeah, you had to monitor all their vitals and everything.
Everything, right. Yeah.
Wow.
Yeah. But then I really believed that the patient came first. So I put it into practice.
Yeah, that's
Dr.
pretty awesome.
Callender, that meant you were a caring doctor, and that's most important to me.
Well, that's what we're here for. Yeah, right. No question. Caring is what it's all about. And
Commitment.
that was my forte.
Yeah.
I had one criteria when I go and talk to a doctor. I try and make eye contact, and if they don't maintain eye contact, or if I reach for them and they flinch, then I select another doctor.
Good judgment, I guess. Yeah. Caring is what it's all about. That's right. It beats almost everything else. Because nowadays, the information is available. So you can find it. Well, any other comments or questions?